I am Professor Dr. Anuradha Chougule. For last 35 years, I have been working in Tata Cancer Hospital, heading the Department of Medical Oncology Molecular Laboratory. I retired in 2018 and now I am as a consultant at Tata Memorial Hospital. Adding to that, now I am as a chair professor at Maharashtra University of Health Sciences, heading the Department of Genetic Health Laboratory, Pune. To add to that, I have also developed my own company called as Genome Intellect Private Limited for education, training, research and diagnostics. Coming to that, with the last 35 years of experience in molecular pathology, I am a basic scientist and day in day out I work on the molecular diagnostic and research. All the tests have been developed on the DNA mutations and RNA mutations against which the targeted therapy inhibitors are available. So, having said that, now with there have been a precision medicine, that is the paradigm shift from a chemotherapy to precision oncology. All the therapeutic tests are developed as a tyrosine kinase inhibitors. So, there are various driver actionable mutations against which the targeted therapies are developed. For example, if you take EGFR, that is epithelial growth factor receptors in lung cancer, which is a very hallmark of the lung cancer, and if this EGFR is present among the given exon 18, 19, 20 and 21, there are various targeted therapies are available today, like it started with the gefitinib, then afatinib, erlotinib and so on. So, with this there have been a progression free and overall survival rate has definitely increased, which was year before like only with a few months, and now it has gone with this TKI therapy, it has increased up to 5 years as well, up to 5 years with not all the patients, but yes 10 to 15% of patients have gone up to the 5 year survival. So, this is the major paradigm shift happened with this tyrosine kinase inhibitor. Particularly in EGFR, there are total 28 exons, out of which only 18 exon 18, 19, 20 and 21 are supposed to be the driver in which you find the driver actionable mutations. The exon 18 and 20, you get to see lot of rare mutations where we need to go actually precisely with the either the afatinib or the recent drugs which are available as a first line generation treatment. Apart from that, TP53 is also being seen frequently in the lung cancer, and this TP53 mutations, if it is close to 50% as a variant allele frequency or close to 100% as a variant allele frequency, we need to look for whether there is a familial cancer of lung in the not only in the lung, but other than that lung do we get to see these mutations, and we have to do the familial study whether there is any lung cancer present in the family. So, this is one of the aspect of the lung cancer. Other than that, in EGFR, we also have to monitor the disease by looking at the liquid biopsy. Why liquid biopsy is important in EGFR testing? Because we can't do the re-biopsy testing frequently because it is very painful and the patients are not ready to do the re-biopsy testing again. So, what exactly is the liquid biopsy? These are the cell-free DNA, where that is the small DNA fragments are shed into the bloodstream, and these cell-free DNA precisely in the malignancy like in the lung cancer, it also carries the circulating tumor DNA. Now, what we see when we do the testing for the circulating tumor DNA, we are measuring the EGFR absolute quantification, how the treatment is effective, are we able to see there is some log reduction value or there is a absolute quantification is responding to the treatment or not. So, this is another monitoring the EGFR lung cancer patients by doing the liquid biopsy testing. Here also we can also do the apart from EGFR, we can also have a bigger panel, because now in lung cancer it is just not the EGFR which is important, but we need to see the IHC markers like EML for ALK, RET, ROS1, NTRK fusions and all those things. So, we can also see this by making a larger panel, and now as per the NCCN guidelines, it has become mandatory to see these various types of mutation to treat the cancer, to treat the lung cancer patients. And other than that, there is a larger panel where you get to see the CDKN2A and PIK3CA, where we need to have the inhibitors for this PIK3CA, but to our dismay, in India we don't get to have this treatment available, and that is the major I think we should look for. Many NGOs should come ahead for this treatment to get these drugs available at the compassionate basis, because poor patients are generally deprived from this the treatment because of the cost is very high and we are not able to treat the patients. Other than EGFR and IHC also, we need to look for the PDL1. Now, what is PDL1 is the again IO therapy related. So, if the PDL1 is positive, that is more than 50%, the patient can also treat with the IO therapy. Apart from again EGFR, there is also a KRAS mutation, where a particular mutation called G12C, where the targeted therapy is available. But again to that, coming to that, we do not have a treatment available in India in particular for this G12C KRAS positive patient. So, this is really very disappointing. Lot of research is happening at the research level, especially when you are looking for the you can say CRISPR-Cas9 treatment which is coming up. That is, you get to also you can call it as a molecular surgery. If you get to see a EGFR mutation, so based on that you can derive some 3D culture in vitro, and you can do the CRISPR-Cas9 treatment by replacing a mutated gene to a wild type gene, that is wild type gene in the sense that is a normal gene. So, this again the research is going on very much by and large in the laboratory. So, I am proud to say once maybe in near future it will be very helpful to have this CRISPR-Cas9 treatment at in vitro for the lung cancer patients. Now, getting connected to the EGFR testing, there are a lot of issues regarding the availability of this FFP block. Now, what is FFP block? These are the fresh frozen paraffin embedded blocks. Now, in particular in lung cancer, it is a challenging thing to get the tissue biopsy, because the site and size of the tumor is very relative, and it is, since it is very close to the heart, it is very challenging to have the biopsy. Most of the biopsy are done under the interventional radiologist to have, or we can say the CT guided biopsy, where the interventional radiologists try to collect this tissue or see the cores which are available. We can't have more cores, not more than at least 5 to 7 cores is very difficult at times. So, we are very particular in getting the tissue. Now, once the FFP block is ready, you need to see what is the tumor content, and once it is diagnosed, and for the morphology it may be adenocarcinoma, it may be squamous, it may be large cell carcinoma, or it may be a mesothelial carcinoma. In particular, the EGFR panel is tested in the adenocarcinoma and the squamous testing. Now, when we come to the selection of the FFP block, we need to see how much is the tumor content in the block. For example, because NGS, next generation sequencing platform, is very sensitive technology. So, for that at least we need to have 20 to 30% of the tumor content. Now, this can be only done by the molecular pathologist, where they mark the tissue on the H&E slides, and then we need to do the macro dissection of these slides, and then we need to collect those paraffin embedded tissue content into the 1.5 ml of the vial. Now, once it is done, we need to see how good is the yield of that DNA or RNA to take it on the next generation sequencing platform. So, at least we need to have a 10 microgram of DNA to take it ahead for the NGS system. But yes, if you want to do the single gene testing for the real time PCR, then only 10% tumor content is also enough, because single gene real time PCR is also a very sensitive technology which we get to see in the molecular laboratory. So, for single gene EGFR testing, real time PCR is the best platform, because you can monitor it by getting the absolute quantification number on the digital PCR as well. But if you want to go ahead on the bigger panel, like on the next generation sequencing, then we need to definitely have a good yield, at least 50 microgram of DNA to take it ahead on the NGS platform. And as I said, if the tissue is an issue, you can also have in the metastasis lung cancer, where you get a good yield of those circulating free DNAs in which the ctDNA are embedded. So, again, for the liquid biopsy is again a choice of test, where we can do either by tissue biopsy or you can do by the liquid biopsy testing. To have more information about this lung cancer, you should join Lung Connect.